Thank you so much, Director. Good morning, colleagues.
Morning.
Hope we are well. Thank you so much for the wonderful introduction. I'll straight away go to the presentation because we don't have so much time. But I want to start with a short story. At the beginning of my career, 9 years ago, in primary healthcare, I was asked to supervise a couple of community health workers in an island located in the middle of Lake Victoria. And the way Living Goods was operating at that time, we had supervisors that were recruited to supervise the community health workers. I visited one of the health workers called Theo, and in the visit, she had not performed as expected. So I asked this lady, why aren't you performing? This lady owned a fishing boat. She owned a store to sell her groceries. She told me, look at me, I have other things to do. I was like, but you just visited 10 households and you have 200. She was like, you're actually lucky I visited the 10 because I have other competing priorities. And so when I joined the innovations team, it brought an idea on how can we leverage on data so that we come up with a solution of precision care. And that's how predictive analytics came in. So the first use case that we came up with was leveraging predictive analytics to identify zero-dose children, missed children through the community health workers. And you can see that's a unique, that is a very common document, which is a child health card. And so the question I want us to bring in the room is not about the presentation, it's about the data that our community health workers have accumulated over the years. How can we leverage on data and machine learning for us to enable this community worker target particular households than asking them to visit every household every month? And so we came up with a solution of, as Living Goods, to think through predictive care, predictive models. We are still trying to find out. And I want us, as we go out of this conference, to think through how do we leverage on data to enable this community worker target the households that are at risk. And some people will call it risk stratification models. Of course, this is about Living Goods, and Living Goods partners with governments in Kenya, Uganda, and Burkina Faso to professionalize community health worker systems and impact them at scale. We have spent over 15 years demonstrating best practices and demonstrating high impact through a desk approach. A desk approach is ensuring that community workers are digitally enabled, they are equipped, they are supervised, compensated to do their work. And we did this and came up with an RCT to see has it worked or not worked. And we saw that this model, the desk model, is able to reduce mortality by 27% for less than $2 per person annually. Let's go back to the topic. Leveraging predictive analytics to optimize immunization coverage. So we start with a team of data scientists and said, we have the predictors. And all of us know that if you look at immunization, and one of the challenges we have, there are known predictors. But of course, the machine learning model that we're trying to use is we get data and feed into a model, or what we call a machine learning model, to come up with an algorithm that will give you a particular model. And of course, for data science, we know that in machine learning, the model keeps developing and evolving, what we tend to sometimes call artificial intelligence. And we know that the child's likelihood of defaulting a routine immunization is correlated with particular demographics, the background of this child, socioeconomic status, gender, maternal education, ethnicity, and location, and of course other factors. So if we have these numbers and these known statistics, we should be able to automate these in the process of an end-to-end process to bring these real-world problems and automate these things so that a CHW she is able to be informed that a certain household is at risk of having a defaulter. And so the methodology we are using, and I'm saying we're using because we are still learning, in collaboration with the Ministry of Health Uganda, in the certain district called Mayuge. Now, how this is working, it means that we shall use the models and the algorithms to forecast future outcomes based on existing data patterns. We know that sometimes there's a pattern that you can follow and know that at this time of the year, it is going to rain. At this time of the year, it's the dry season. And we know it. How about we also use the same data that we have accumulated and know that households that are perhaps last mile tend to default, mothers that perhaps give birth through traditional birth attendants are likely to have zero dose children. How about this kind of data to come up with a model? And of course, we use research indicators, as you can see over there, looking at the data at the facility, the data recorded by the community health workers, and we fed this data into different predictive models. And of course, it was a very new area for us, because living with pioneers in ICC, family planning, nutrition, and other things, but not in machine learning. But personally, I come from a program of innovations. We thought of doing this in phases. Like I said, it wasn't easy. But the first thing we thought about was how about we develop an algorithm using data. And with the data sets we had, we thought of looking at distance to the facility. If someone is far from the facility, chances are they will not go. If the child is not sick, why would you prompt someone to go to the facility? So that's a potential defaulter. If you look at the number of antenatal care visits, if someone's record has one visit, two, chances are high they will miss out on immunization. If you look at other factors as listed there, talk of birth registration, talk of stock-out records at the facility, all those correlate to zero dose children and defaulters. We go to the second phase and say, okay, the first model that we had gave us an accuracy that was close to 80%. That was on the desk. So went to the ground and said, okay, let's try to see the ground truth on the ground. What does the data say? So we went to test the algorithm on what we call ground truth testing, and we set out to find the accuracy. And we found that this gave us from 80, it dropped to 68%. And so with we have the performance evidence and design team, they said, but this is so low. And for data sets who are here, you know that this is so low. 68% is very low. But we said, nonetheless, this can be improved. We are innovating, we are learning. We went the second phase and said, let's put this into practice. Let's learn. And we found that with continuous improvements, this can give us something else. So I went to the ground and I'm going to show you what did we find on the ground. So this was before the electronic community health information system, so we're doing this internally as living goods. And we found that true, majority of the defaulters were affected by distance to the health facility. Some are talking of fear of adverse effects, and indeed, some mothers forget. And of course, stockouts at the facilities. We did this for 1.5 months, and the model was able to flag 112 children that were at risk. And out of these 112 children, the community health workers now were able to be guided on which child to see. And 72 of those were followed up, and 36 of these completed the immunization schedule. Now, interestingly, we had a false positive rate of 68.3%, meaning that the probability of finding a defaulter by the community health worker was 10.7%. And so we think we can still improve this. And of course, we asked one of the community health workers, the challenge of immunization. I didn't want to go into the statistics. But of course, she mentioned that 7 years ago, parents used to hide their children from us because of fear of misinformation, and that was either aware, who is supported by living goods. But now, 9 out of 10 children are vaccinated because of the application. The ETS application and the living goods application was able to give us the data. And of course, the reminders that they were able to receive would direct them particular households to support. Now, interestingly, we went out to find out at the end of the experiment, which is still evolving, what are the defaulters saying? Is it because they want to default? Is it because we think that they don't have access? What are they saying? Interestingly, before the study or before the experiment, we went to find out some of the barriers. And this is what they mentioned. Limited access, of course, physical access, that is distance, fear of adverse effects. And about this, we learned that most of our health workers at the facilities, because of the long queues, they line up and say, we are giving DPT1. They don't even tell the mother about the temperature that will come by. They just pinch, they vaccinate, and the children go home. Now, the adverse effects come, the child starts vomiting, they get high fever, and the mother says, I'm not going back for DPT3. And we ask the question and we say, we have so many defaulters, but because we are not giving sufficient education on that. Talk about the grandmother raised children. I visited the household and I found the child, and this was guided by the model. The child was being raised by the grandmother, and the mother left the child in the hands of the grandmother and went to Saudi Arabia to work. The mother had no clue, the grandmother had no clue that this child needs to go for immunization at 6 weeks. So the grandmother raised children are potential defaulters. Talk about myth and misconceptions. Talk about competing priorities. This cannot enable the mother for it. And so, how do we support communities to be reminded of their schedules? Talk about home deliveries. Now, intriguingly, the mothers who were able to go, like you saw the previous slide, they told us they forget. Why did you take the child on the eye? I forgot. Why did you forget? I even don't know that I'm supposed to go back. Why? The health worker writes, gives back the book or the card. If you don't know how to read, that's your problem. Talk about beliefs, fear of adverse effects. I think I talked on that. Someone told us that the schedules are so many. You have DPT1, DPT2, DPT3. You have measles coming up. What do you want them to do? Talk about stockouts. Some actually mentioned that to us that these are cancer agents because of the misinformation. Talk about single mothers. Talk about waiting for outreaches. They don't know when outreach is happening because of poor communication. And so we think more reviews are needed to refine the algorithm from our end so that we can automate this process and inform programming, and of course addressing hesitancy. And we think precision support should be able to support the community health workers to focus on which households to visit. Talk about SMS reminders that should be able to help. And finally, as we get out of this room, colleagues, let's think about this community of work we are talking about every day. How do we ensure that we leverage on existing data? How do we ensure that we leverage on predictive analytics, proactive care, micro-targeting, and also ensure that we are able to support the last mile? It's up to our to evolve and innovate around machine learning and support the community of workers. Thank you for listening.
Thank you very much, Alfred, for addressing all issues about health, because ever since the public health professional was a public health professional, the key concern was how to reach everybody. Why is that everyone knows that people are important so that these gaps are addressed and coverage for all